Hi and welcome to the medical theme. This video is on pneumonia. So as an introduction, I'd like to ask a couple questions just to get a brief idea of what you already know about the topic. So question 1. What is the underlying pathophysiology of pneumonia? Inflammation of the lung due to infection, obstruction of the airway, or an inadequate blood supply to the lungs? And the answer is A. Inflammation of the lung tissue due to infection. Question 2. Which of the following symptoms would you not expect in a typical patient presenting with pneumonia? A. A fever. B. Purulent sputum. C. A dry cough. Or D. Malaise. So knowing that pneumonia is infective, which of these may not fit that history? And the answer is C. A dry cough. You'd probably expect, if the patient has a cough, for it to be productive. So pneumonia, in this presentation we're going to cover what it is, we're going to go over the symptoms and history, the epidemiology, investigations and differentials, clinical exam of a patient with pneumonia, its management, and then summarize all of the above with a couple of multiple choice questions fitted into a case. So what is pneumonia? Pneumonia is an acute lower respiratory tract infection that shows radiological change, which is called consolidation. Pneumonia is broadly classified into three categories. The first being CAP. So CAP stands for community-acquired pneumonia, and it may be primary or secondary to an underlying disease. Common organisms that cause CAP include Streptococcus pneumonia, Haemophilus influenza, or Mycoplasma pneumonia. You then have HAP, which is hospital-acquired pneumonia. HAP refers to a pneumonia that occurs over 48 hours following hospital admission, up to 2 weeks leaving hospital. Organisms known to cause HAP include Staph aureus, Pseudomonas, Klebsiella, and C. diff. The last of the three main categories is aspiration pneumonia. Aspiration pneumonia occurs when a foreign body enters the lungs directly and introduces bacteria to the environment. Individuals with decreased consciousness, esophageal disease, neurological deficits, or poor dental hygiene are all at risk of aspiration and therefore at risk of aspiration pneumonia. Symptoms. There are a number of symptoms that you might see in a patient with pneumonia. A good way to think about them is linking them to the pathophysiology underpinning the condition. So knowing that it's infective, it would be common to see fever, malaise, anorexia nervosa, so a loss of appetite, and rigors. And then knowing that it affects the respiratory system, it's common to see the patient report dyspnea, a cough, purulent sputum, and pleuritic chest pain. Potentially may see hemoptysis as well, although it's probably a little more worrying. The history of a patient with pneumonia typically expresses sudden onset dyspnea, productive cough, and infective symptoms, and that these symptoms will then progress quite rapidly over a matter of hours or days. When taking a history from a patient with pneumonia, it's always a good idea to consider potential exposures to infection and also assess the risk of aspiration by asking about their alcohol intake, drug use, and any past medical histories that may be relevant. Epidemiology. So who does it affect? Well, pneumonia is a very common condition, typically affecting 8 in 1,000 adults each year. It's typically more prevalent in autumn and winter, as are most respiratory infections, and in theory anyone can get pneumonia. However, there are certain groups of the population at greater risk. These include the young and the elderly, and it also includes individuals who are immunosuppressed. So, for example, those having chemo, those who are on immunosuppressive medications, or those with HIV. In terms of investigating pneumonia, it's always a good idea to start with vital signs at the bedside. You can also take the patient's blood, and you could do a full blood count, so that will look at the white cell count, and you could also look at inflammatory markers, which both you'd expect to be raised in the case of infection. You could also take a blood culture, however it's much less common and typically only really useful if you suspect the patient's become septic, so the infection spread from the lungs into the blood. You could take a sputum culture as well, so test the sputum that's produced when coughing for any microorganisms that may be present. And finally, and most importantly, also a chest x-ray. This is really important to make a diagnosis of pneumonia, as per the definition, pneumonia has to show radiological change. When considering a patient with the symptoms consistent with pneumonia, it's also important to think about some differentials that could also be the case, and ideally exclude or include them. So, common differentials to think about would be a lower respiratory tract infection, which presents identically to pneumonia as it has the exact same pathophysiology, except it shows no change on chest x-ray. Also, you can think about asthma. So, asthma, unlike pneumonia, would probably expect a longer term history with episodic symptoms. If the patient reports having a cough, an asthmatic cough tends to be dry, and when investigating to check for asthma, you could consider doing a peak flow or spirometry, which would be obstructive in asthma but more likely restrictive in pneumonia. However, it should be noted spirometry is effort dependent, and if a patient's very ill, it may be difficult to get them to comply with that. Another differential to consider would be an infective exacerbation of COPD. Now, this is a little bit of a grey area. The patient will typically present with the same signs and symptoms. However, it should be noted that a patient with COPD is still able to get a pneumonia superimposed onto their condition. So, an infective exacerbation could in theory still be pneumonia. However, more likely it will just be an infection, and therefore you won't see any radiological change on x-ray. When managing a patient with pneumonia, you first need to assess its severity. Severity is scored using the KERB 65 score, where each of the following criteria scores 1 point. Confusion, ideally new onset or worse from baseline. Urea of greater than 7. A respiratory rate of over 30. A low blood pressure of less than 90 systolic or less than 60 diastolic, or the patient being aged over 65 years old. If they score 1 on the KERB scale, then typically the patient would be managed at home with oral antibiotics such as amoxicillin. If they score 2, the patient should be considered whether or not they need to go to hospital, and typically they'll be managed with amoxicillin and clarithromycin. And KERB 3, 4 or 5, the patient should be admitted to hospital, and in the higher scores consider ICU admission. In terms of managing these patients, you'll typically use IV coamoxiclav and clarithromycin. At this point, it should also be mentioned that antibiotic guidelines vary between different trusts, and so it's important to consult the local guidelines to the hospital you're working in. In terms of managing the patient's oxygen levels, oxygen therapy should only be used if the patient is not at their target saturations. So in CO2 retainers, that would be 88 to 92%, but for the majority of people, you're aiming for 94 to 98%. On examination of a patient with pneumonia, as with most respiratory conditions, on inspection you're looking for any signs of accessory muscle use, peripheral or central cyanosis, or any confused or altered mental state. On chest expansion, you'd expect it to be reduced on the affected side, and on percussion over the area of consolidation, you would expect a dull note. On auscultation, you may hear bronchial breath sounds and coarse crackles, with increased vocal resonance over the area affected. OSCE tips. So bringing that all to wraps, when thinking about a patient with pneumonia in an OSCE setting, be sure to ask about time frame and symptoms. This will help you differentiate between other common respiratory conditions. You also, when taking the history, should think about trying to ask about exposure to risks. So for example, the risk of aspiration, as previously mentioned, and also any recent travel, pets, etc. On examination, make sure you take time to assess the patient thoroughly. If there are any areas you're unsure about, it would be well worth your time making sure you are able to distinguish one sign from another. So summary. So to summarise, I've got a short case that we're going to read through together, and following it we'll have a couple questions. So the case. John is a 78-year-old gentleman who's presented to his GP with his wife who cares for him with dyspnea, a sharp stabbing pain, and also coughing up thick, mucky sputum. He's been feeling generally unwell and not himself. During the history, the GP finds that John's known to have dementia. He had a PE in 2013, and he was in hospital 10 days ago with a bout of diarrheal illness. There were no other significant findings. The GP suspects John has pneumonia and admits him to hospital for investigation. Should the diagnosis of pneumonia be correct, which type is John's most likely to be? Is it CAP, is it HAP, or is it an aspiration pneumonia? As a little hint, it's worth your time thinking about John's past medical history and also his recent health. All things considered, it appears that John's pneumonia is a HAP. This is because it began within the 2-week window of leaving hospital. So John then goes to A&E and was examined by the consultant. His bloods were taken, and on examination he was found to have dull percussion note, bronchial breathing, and increased vocal resonance at his right base of his back. On chest x-ray there's consolidation, and he was subsequently diagnosed with pneumonia. His OBS were as follows, and on blood tests his urea was 7.3 and his lactate was 1. What is John's CURB-65 score given his recent diagnosis of pneumonia? Is it 1, 2, 3, 4, or 5? As a clue, of course, try and consider what each letter of CURB stands for, and 65 at the end, and try and work out from that paragraph which he scores. So the answer is 4. So this is because John is no more confused than normal, so therefore he doesn't score for confusion. U stands for urea over 7. In this case, John's is 7.3, so that's 1 point. His respiratory rate is over 30, that's 2 points. And his blood pressure is low, as his diastolic is under 60, so that's 3 points. John is also 78 years old, so therefore that also counts as a point, giving you 4. So, given John's CURB score is 4 and his saturations are 94% on room air, which would be the most appropriate management plan according to the guidance based in this presentation? First, send home on oral amoxicillin. Suggest that John stays in hospital, give oral amoxicillin, clarithromycin, and oxygen. Suggest John stay in hospital, give coamoxiclav and clarithromycin. Or D, suggest John stay in hospital, give IV coamoxiclav, clarithromycin, and also oxygen therapy. So consider his past medical history findings in question 1. That will be helpful in answering the question. So the answer is C. So John should stay in hospital, definitely, with a score of above 3. He should be given IV coamoxiclav and clarithromycin, as is the case with anyone scoring above 3. However, with regards to oxygen therapy, it was previously discussed that in the first question, John had no past medical history of COPD, which makes it even more unlikely that he's a carbon dioxide retainer. That means his saturation levels are aimed at 94 to 98. So although they're low on that banding, he is still within limits, and so no oxygen is required at the moment. Thank you for your time. I hope this video was useful.